So this is a very important question, has to be answered. See, heart failure who are admitted for decompensation can be divided into two. One who had a chronic heart failure in the past and now has admitted for the acute decompensation, versus a de novo heart failure. For the first time he is hospitalized for the heart failure. There were no prior known reports or history suggestive of heart failure. That is called as de novo. So it is important to differentiate these things, because de novo heart failure is something which is for the first time, so they have lesser morbidities or comorbidities are lesser. They are not into the advanced stage of heart failure, and that is why they respond much better to the line of treatment. Two, their prognosis is also better if we intervene at the correct time with the correct drugs. So that differentiates. While a chronic heart failure getting decompensated has to be because of something else, either infection, arrhythmia, drug induced, or something has happened and that's why he's back again with the heart failure. But we know that each episode of heart failure takes them down to the spiral and recovery is never full and their prognosis progressively deteriorates. Now coming back to our question, when to add ARNI. So there was a pioneer HF trial which was done to address this question, where around 1000 patients were studied. What it showed, pioneer showed, कि the moment we add the ARNI, the benefit starts as early as 1 week. 2, it can be added in hospital. Pre-discharge is the preferable time where we can add this ARNI. So any patient of heart failure, once he comes, let him stabilize with the symptom relieving drug, find out the etiology, whatever decompensation issues, we can tackle it for a day or two and then initiate the patient on ARNI. So this was the pioneer which showed much better results if the patients were on enalapril arm versus ARNI arm. The benefits were visible, as I said, as early as 1 week. So by the time he is due for the next follow-up, you are having the results that your patient is doing much better in terms of heart failure treatment. Now we can break down this into further subsets, like whether it was de novo or chronic heart failure, they derived good benefit of this. Whether they were on prior ACRB and now you have shifted to ARNI, still they got the benefit, versus they were never on any ARNI and you started it first time with the ARNI. So that is called as treatment naive. Both derived the benefit. Even the benefit consistent across whether the prior BNP were high or similar to the normal. Both the group derived the benefit of ARNI. So ARNI should be added as early as possible in the history of heart failure. That's why a reasonable decompensation, reasonable stabilization and pre-discharge you can start with the ARNI. The prior paradigm was there where it was a stable heart failure, at least 40 days, stable heart failure, and then we were adding ARNI. Now we are coming closer and closer. So maybe down the line we'll have some other trial where if a heart failure with a good blood pressure or a preserved blood pressure, or with an increased blood pressure and a preserved renal or potassium parameters, maybe we can add on admission also. But we have to yet wait for the evidence of it.